My name is Neha Mehta-Shah. I'm from Washington University in St. Louis. I'm a medical oncologist. So I'm a cancer doctor, and I specialize in the treatment of patients with T-cell lymphoma, and specifically also in patients who have cutaneous T-cell lymphomas. We work in an interdisciplinary clinic here at WashU between dermatology and radiation oncology and medical oncology. So we're fortunate to have a great team to treat patients with this rare disease. So cutaneous T-cell lymphoma is a rare type of lymphoma that appears on the skin. So some patients just present with patches of scaly or red skin or itchy areas that often looks like eczema or psoriasis or some much more common benign skin conditions. And some of these patients see their dermatologist. They may or may not have had a biopsy, and many of them get treated with topical or skin-directed therapy, whether that's creams or lotions or ointments or things like phototherapy, like light therapy. Most of those patients, fortunately, have a normal life expectancy, but they still do suffer from issues of quality of life. In our clinic, we end up seeing some of the patients who have a higher burden of skin lymphoma, whether they have tumors or they have a higher level of their body involved with CTCL. Some of those patients have plaques, so raised areas on the skin. Some of them, such areas, will have ulcerations or breakage or skin breakdown or bleeding or fissures on their hands and their feet, which can be very uncomfortable. Some patients will end up having disease in their blood or lymph nodes or even other organs. And those patients often need more significant treatment, whether that be in the form of pill medicines or IV treatments, and then sometimes even are considered for things like stem cell transplant. So the range of patients with skin lymphomas varies very widely, and their prognosis also is highly variable. So patients who have early stage disease, we believe, have a normal life expectancy, no different than their friends and neighbors. But patients who have more advanced disease can pass away prematurely. The diagnosis of this disease can be really challenging, because it's rare. Most dermatologists or primary care physicians haven't encountered this disease or not frequently, and it shows up differently in different people. So there are some people for whom they have just patches of disease on their skin that looks like eczema or psoriasis, but then there's people who are literally red from head to toe and scaling. They look like they have a permanent sunburn on their whole body. And some patients have tumors, and some patients have flat areas. Some people have raised areas. And so it looks different in different people. And in particular, it also looks different in people with different skin tones. So we've noticed patients who have Caucasian skin or fairer skin tend to present with red areas, whereas patients who have higher pigmented skin, like some of our African American or Black patients, tend to present with lighter areas. So it can make it challenging to visually diagnose the disease. Additionally, the skin lymphoma cells make up a very small part of the skin biopsy. They have an unusual appearance, but sometimes it's really subtle to be able to tell on a skin biopsy. So the average patient goes to 2 or 3 biopsies. 5 or 10 years ago, we used to actually quote patients that it could take up to 5 or 7 biopsies to make a diagnosis, because that was, and some of our newer technology using things like genetic sequencing to look for something called the T-cell receptor sequence has made our yield a little bit better with biopsies. So it's taking a little bit less, but it's still taking more than one for most patients. And because doctors will think that this is a more common disease before it's a more rare disease, which is normal, in medical decision making, oftentimes patients are thought to have what we call atopic dermatitis or psoriasis or eczema or something else, or an infection, before they're diagnosed with cutaneous T-cell lymphoma. It's not usually the first thing that comes to mind. So it can take years to make a diagnosis. Some of the epidemiologic studies suggest it takes 7 years. The average patient, by the time they're diagnosed, might have had it for 7 years. And so it can be incredibly challenging. And so, when there's suspicion, we usually recommend that the pathology or the skin biopsies go to a reference center. There are multiple commercial reference centers or academic centers to have them reviewed, because sometimes they'll use like that other technology to help make and confirm the diagnosis. And hopefully that process will get better and better as it has. There's so many treatments that are available for patients who have skin lymphoma. They're often not FDA approved because given this is a rare disease, there's not always studies done specifically to get drugs FDA approved for this condition. So we often borrow from collective experiences. And To me, when we talk to patients about how to manage their care, the goal really is to treat them with medicines that make their day-to-day better. We know that they're often suffering from side effects of having the disease, and we certainly don't want the side effects from treatment to make it be worse than the side effects of living with the disease. So our mantra in our clinic often is, we want to make sure that we don't make the problem worse, and we want to make your quality of life better. Don't make the treatment worse than living with the disease. Therefore, symptom management is a huge part of treatment of patients with skin lymphomas. The truth is, when their lymphoma is under better control, their symptom burden is often less. And so treating the lymphoma does help to palliate their symptoms, whether those be itching or skin breakdown or skin fissures or pain or discomfort. Many patients suffer from insomnia and suffer from anxiety, depression related to their disease as well. And fatigue is certainly a component as well. The skin sometimes gets really scaly. These patients have to live with other people being able to see what's going on with their bodies. So they often feel a sense of social isolation. They feel reluctant to do things that we often take for granted, like go to school events and go to the grocery store and socialize with friends and family, because people can see what's going on with their skin. And sometimes they feel that they are more comfortable not being exposed to other people. I think a lot of people have misconceptions about what this disease is. And because it can show up on your skin, they often get a lot of questions about what's going on. And those are sometimes difficult to answer to people that they are not as close to, especially. Quality of life issues, I think, are very central in the treatment of this disease. As I mentioned before, the goal of the treatment is to improve their symptom burden and not let the side effects of the treatment become worse than the symptom burden of the disease. So we often try to pick well-tolerated medicines that don't have what we call cumulative toxicity or develop worsening toxicity or side effects over time initially. And if we can get a good disease control with that, then we would prefer to use those as opposed to medicines that tend to cause more side effects over time or more side effects immediately. But we also want to balance that between drugs that we know work well. And so it's a shared decision making with the patient and the family and caregivers about what is the best treatment for them. So people who have jobs where they can't come for treatment once a week or can't come for things like phototherapy multiple times a week, we try to make sure that whatever treatment we're picking matches up with the other things going on in their lives, because really we want them to be able to live their lives and do the things that they want to do and want to minimize the hindrance of having this disease. So I think quality of life is very central. There's been lots of studies of trying to look at quality of life because of the unique nature of this lymphoma being on the skin and having an impact both on their appearance and their social interactions, in addition with the physical discomfort and the insomnia and the pruritus, which tend to be a big problem. It uniquely affects quality of life much differently than other types of blood cancers or other types of lymphomas. So we've done studies here at WashU to demonstrate that even if you take people who have other skin conditions like psoriasis or eczema, and you measure standard quality of life tools, and you look at people's quality of life if they have eczema encompassing 30% of their skin versus CTCL encompassing 30% of their skin, patients who have CTCL have significantly worse quality of life. And then if you look at the other things like insomnia, depression, anxiety, itching, they're all significantly worse in patients who have CTCL. And those are not, unfortunately, well measured on current quality of life tools. It takes doing like 5 or 6 or 7 quality of life tools to really get a full picture of how patients with skin lymphoma feel on a day-to-day basis. And so one of the things we're working on is developing a quality of life tool that's specific to skin lymphoma. We have interviewed our own patients about what's important to them, recognizing these deficits we've observed over years, doing systematic studies. And with patient feedback, have developed a 20-question quality of life tool that we're hoping to now validate at multiple centers, in hopes that that will give patients and doctors a better tool to measure quality of life and kind of guide decision making, or give a way to quantify how someone's feeling on a day-to-day basis. Patients with CTCL will say they're literally tormented by their itch. Like they have an itch that is unrelenting. It tends to get worse at nighttime just because there's a circadian rhythm to itch, like there's a circadian rhythm to sleep. It is often debilitating. It leads to patients not being able to sleep and get a good night's rest for many, many weeks and months. The itching can get so bad that they'll wake up with like multiple scratches and bloody sheets because they're itching all night and scratching all night. So it's really a huge issue. They'll tell you they feel like the itch is coming from within and it's like all over their body. So some of the medicines that we pick to treat this disease, we will look at like what the burden of the itch is and kind of lean on medicines that we know do a better job of treating the itch while also treating the lymphoma. So I'll give you one example. In patients who have Sézary syndrome, where they have a higher proportion of blood disease or leukemic involvement with their skin lymphoma, those patients tend to be red all over and they tend to have an even higher rate of a severe itch compared to other patients with CTCL. And there's some drugs that are now particularly effective at kind of clearing the blood, like mogamulizumab, which was approved a few years ago for cutaneous T-cell lymphoma. And that drug not only can clear the blood in over 2/3 of patients, which was very remarkable, but additionally, in studies that PG Porcu and others did looking at quality of life, demonstrate that even within the first month of treatment, people's quality of life dramatically improves. And a large part of that was also looking at itch scores and seeing that the itch improves. Anecdotally, I'll tell you, we have some patients who, after getting 1 or 2 doses, they feel like their itch is almost gone, which, they haven't experienced before. And so when patients have severe itch, we sometimes will lean on medicines like mogamulizumab, especially when they have Sézary syndrome, because we know it potentially can address some of the issues that they are having that are at the forefront of their impairment in quality of life. But yeah, the itch is super, super important, and it's often very hard to control. In addition to treating the lymphoma, we have other medicines that sometimes are helpful for itch. Those include medicines used for neuropathy, like gabapentin or Cymbalta or duloxetine or pregabalin, which is Lyrica. And those medicines can be used for pruritus or itch as well. And so sometimes we'll use those. Sometimes patients take medicines like Benadryl or the equivalent of those, but those often make people sleepy too. Similarly, we'll sometimes use some of the more common allergy medicines that are over the counter, which also can help generalized itch, but they seem to not relieve the itch completely.